All right, let's dive right in. Today we are tackling the uncooperative hip, which, can be one of the most complex puzzles we face in the clinic. And look, this isn't just about acing your OCS exam. This is about building a rock-solid, evidence-based system so you can walk into any room and competently figure out what's really going on with hip pain. We're going to build that system together, piece by piece, starting right now.
So let's start with a scenario that I know you've all been in. You've got this patient, you're 6 weeks in, you're throwing everything you've got at what looks like a simple hip flexor strain and nothing. Crickets. You start to second-guess yourself. Is it just a stubborn strain, or is there something bigger, something more serious that you're missing? This exact situation is why we need a system. Because the hip, it's a master of disguise. It can be screaming pain, but the real culprit could be the lumbar spine, the SI joint, or even a systemic disease. Our job is to be the detective, and every great detective needs a plan.
And this is our game plan for today. Think of it as your diagnostic roadmap. We always start with the highest priority, screening for those can't-miss red flags. Then, we check out the neighbors, the lumbar spine and the pelvis. Only after we've cleared those areas do we earn the right to really focus on the hip itself. Then, we'll put it all into practice with a case, lock in the knowledge, and finish up with the 5 key takeaways you can use tomorrow. This order isn't random. It's the safest and most effective way to practice.
Okay, first things first. Before we do anything else, our #1 job is to keep our patients safe. And that means our evaluation has to start by looking for the scary stuff, the sinister pathologies. We're talking about systemic issues, inflammatory conditions, or major trauma that can masquerade as simple hip pain but really need an urgent referral. This is our safety checkpoint.
So one of the first things that has to be on your differential radar is inflammatory back pain. I'm talking about things like ankylosing spondylitis. Now, you might think of it as a spine problem, but it absolutely can show up as hip pain, and this is a whole different ballgame. It's not going to get better with our usual mechanical treatments. This needs a rheumatologist. So the million-dollar question is, how do we spot it?
Well, thankfully, we've got a fantastic tool for this, a clinical prediction rule from Sieper and colleagues. Let's just walk through the 5 criteria. Number 1, the patient is under 40. Number 2, the pain kind of crept up on them, insidious onset. Number 3, and this is the big one that can trip people up, their pain actually gets better with exercise. Number 4 is the flip side, rest doesn't help at all. And number 5, that classic story of waking up with pain in the middle of the night, but it feels better once they get up and start moving around.
And here's where the evidence becomes so powerful. If your patient checks off 4 or more of those 5 boxes, this rule has a specificity of 92%. So what does that mean in the real world? Well, when a test is that specific and it's positive, you can be incredibly confident ruling the condition in. A positive test here pretty much means an inflammatory process is likely, and it's time to pick up the phone and make a referral.
All right, next up on our can't-miss list is avascular necrosis, or AVN. This is a nasty one where the blood supply to the femoral head is compromised. So you're thinking insidious hip pain, been bugging them for over 6 weeks, usually in someone between 30 and 50. But listen, the absolute most critical question you have to ask is about their history with corticosteroid use. It is far and away the most common cause of non-traumatic AVN. And be careful, in the early stages, their range of motion might look totally normal, which can really throw you off the scent.
So this brings us to bone stress injuries. It's really important to understand that not all stress fractures are created equal. You've got fatigue fractures, which is basically applying an abnormal, crazy load to a perfectly healthy bone. Think about a runner who decides to double their mileage overnight. Then you have insufficiency fractures. This is a totally normal load, like just walking, on bone that's already weakened, maybe from osteoporosis. The why is different, but the clinical concern is just as high for both.
So who should have your spidey senses tingling for a stress fracture? Well, if they've had one before, that's a huge red flag. For endurance athletes, we know being female is a risk factor, and that means you absolutely must be comfortable screening for the female athlete triad. We're talking low energy availability, menstrual issues, and low bone density. And of course, the classic story you always have to ask about. Have you recently made any big changes to how much or how hard you're training?
Okay, so you suspect a fracture, but you can't just poke around and find it. What do? This is where the patellar pubic percussion test comes in. It's a really slick, simple test. You have your patient lying on their back, you put your stethoscope right over the pubic tubercle on the side you're worried about. Then, you just give a little tap on their kneecap on that same side. You're listening for the sound to travel right up the bone. And the most important part? You have to compare it to the good side.
And what are you listening for? It's pretty simple, actually. A nice, clear, sharp sound is what you want to hear.
But if you get a dull, muffled thud, that's your red flag. That suggests there might be a crack in the bone messing with the sound waves. It's a great test for femoral fractures. But a quick word of caution from the research. The evidence for its use with stress fractures specifically is still a bit limited. So use it as a very important piece of the puzzle, but not the only piece.
Okay, so red flags are cleared. Awesome. Now it's time to check the neighbors. Remember, pain at the hip doesn't always mean pain from the hip. The lumbar spine and the SI joint love to refer pain down there. So before we zoom in, we have to do our due diligence and screen the whole neighborhood. So what are our big hitters here? Well, the prone instability test is decent for looking at lumbar instability. The active slump is a really solid test for neural tension, but the one I really want you to focus on is Laslet's SIJ cluster. If you perform a provocation test and get 3 or more that are positive, look at that sensitivity, 94%. And you know what that means, right? With a number that high, if the test is negative, you can confidently rule out the SI joint as the main problem. It's a powerful way to clear a region and move on.
All right, you've done the hard work. You've cleared the scary stuff. You've checked out the neighbors. Now we've earned the right to zoom in and really put the hip joint itself under the microscope. This is where we start hunting for those specific impairments in muscle length, strength, and mobility.
So when we get to the local exam, muscle length is a fundamental piece of the puzzle. The modified Thomas test is your workhorse here. It's so efficient, giving you a look at the ilio-psoas, the rect-fem, and the TFL all at once. But you gotta watch your stabilization. Don't let the patient cheat by arcing their back. For the TFL and IT band, you've got the Ober test. Just be careful they don't fall into hip flexion. That's the classic mistake. For the hamstrings, we've got the straight leg raise and the popliteal angle. And hey, don't forget to check passive abduction for the adductors. Documenting these things really helps paint the full picture of what's going on.
Okay, enough theory. Let's make this real. We're going to walk through a case and put our entire diagnostic roadmap to the test. This is where you get to play detective and apply everything we've just talked about.
Let's meet our patient. We've got a 22-year-old female, a collegiate cross-country runner. She comes in with deep right anterior groin pain that started about 4 weeks ago. It didn't happen suddenly. Pain is a 7 out of 10 when she runs, but goes away completely with rest. And here's the kicker. She just ramped up her weekly mileage to get ready for the season. The alarm bell should be ringing pretty loudly right now.
So I want you to actually pause for a second and think about this. Before we've even laid a hand on her, just from that story, what diagnosis is screaming at you? What specific risk factors are jumping out from her history? You've got her age, her sex, her sport, the pain behavior, that training error. Put it all together. What do you think is going on? Go ahead, lock in your answer.
Okay, to really nail that case, you need some key facts right on the tip of your tongue. So let's lock it in. We're going to do a quick retrieval practice. And this isn't just a quiz to see what you know. The act of forcing your brain to pull up information is actually what cements it in your long-term memory. It's a powerful learning tool. You ready? Let's go. All right, here we go. Rapid fire. Question 1. The Laslet SIJ cluster, 3 or more positive tests. What's the sensitivity and specificity? Question 2. What's the medication history that's a huge red flag for atraumatic AVN? And question 3. Name those 5 criteria for inflammatory back pain. Go.
Let's see how you did. For the SIJ cluster, it's 94% sensitivity and 78% specificity. The medication for AVN is, of course, corticosteroid use. And the 5 criteria for inflammatory back pain are onset under 40, insidious onset, it gets better with exercise, no better with rest, and that classic night pain that improves when they get up. If you nailed those, fantastic. You're well on your way.
We have thrown a ton of information at you today, so let's boil it all down. If you forget everything else, these are the 5 key things I want you to remember. The things you can take with you and use in the clinic tomorrow morning. Here they are, your 5 clinical keys. Number 1, safety first. Always screen for red flags. Use your tools, like the CPR and the percussion test. Number 2, the history is king. The clues for things like AVN and stress fracture are almost always in the story the patient tells you. Number 3, widen the lens. Check the Mabers, the spine, and the SI joint. Number 4, trust your numbers. Use stats like sensitivity and specificity to guide your thinking. And number 5, don't be afraid to carefully load it to provoke it. A single leg hop can tell you a lot when you suspect a stress fracture. And by the way, for our runner in the case, following these exact 5 steps will lead you straight to the correct diagnosis, a femoral neck stress fracture.
So that's our deep dive into the uncooperative hip. But here's the real test.
My final question for you is this. What is the one thing you are going to do differently in your very next hip evaluation? What are you going to add or change to be more thorough, more systematic, and more confident that you never miss a thing? Think about it.